A very warm welcome to all of you. We appreciate you taking time off your busy schedule. Ladies and gentlemen, please be seated as we are about to begin. I have a few housekeeping announcements to make before we begin today's program. First, I would like to seek your cooperation to switch your mobile phones to silent mode. Those who park at GMC may obtain ticket validation for single entry parking fee at a fixed rate of 3 ringgit from the GMC counter outside during lunchtime. Thank you for your cooperation and attention. Good morning, respected resource persons, sponsors, invited guests, participants, members of the organizing team, FADA, and Gleneagles Penang. Ladies and gentlemen, my name is Joanne, MC. I'm the Program Coordinator at Penang Family Health Development Association, or FADA in short. I work closely with many of the people wearing blue in this room to make this event a reality. On behalf of Penang FADA, I would like to extend a very warm welcome to all of you. We appreciate you taking time off your busy schedules to join us today. We hope you will learn a lot today as we have lined up a fruitful and engaging seminar. Pregnancy Pit Stop, Things Your Mother Never Told You, is a seminar which is jointly organized by Penang FADA and Gleneagles Penang. The main aim is to update you on the various issues and remedies for people to have the children they want for a happy and balanced family life. To begin this seminar, I am pleased to invite Dr. Gan Kam Ling, the organizing chairman and executive member of Penang FADA, to deliver the welcome remarks.
Good morning, ladies and gentlemen. Good morning. Oh, this is like a class. Thank you, Joanne, for introducing the seminar. For your information, this is a landmark event. It is a landmark because it is a close and successful cooperation between two bodies. One, a successful NGO, and two, a successful corporate entity. And I'm also glad that because of this 6 or 7 months of preparation, we have now reached the ultimate aim. We have got maximum capacity for this seminar. Any more than this, you might have to stand outside the room. Now, in addition to this, we have reached out to more than tens and thousands in the digital world. So this is the other landmark of the seminar. We are doing this digitally as well. So please be reminded and be informed that you will be recorded and videotaped, and who knows, go viral later. There are many people I'd like to thank to make this event so successful as it is today. Firstly, it is Gleneagles and the CEO, Mr. Ivan, for his close cooperation in allowing the use of the facilities in this hospital. FADA, of course, my favorite NGO, whom I've been with for the last many, many years. Thank you, NG and team from FADA, the volunteers, Pini, Ivy, Jackie, Joanne. The Gleneagles team is remarkable. The engineering department, the PR, IT department, the girls at the back, staying on just to get everything working. And of course, I'd like to thank the speakers who have put in so much effort to give us a very informative session this morning. The Bar Council too, I'd like to thank you very much. This is again a landmark cooperation between the private sector, the NGO, and the Bar Council. And of course, lastly, our sponsors, CryoCort for allowing us to go digitally, and to thank Rebel Berry for the digital outreach, First Line for the vitamin specimens that you're getting, MSD, as well as Simplified Art, who will be recording the video for us with compliments. So thank you for your attention, and please enjoy the day.
Now, I would like to introduce our first speaker, who most of you had the privilege to be acquainted with just moments ago. Dr. Gan Kam Leng is an experienced consultant obstetrician and gynecologist at Gleneagles Penang. Dr. Gan was awarded a Singapore government scholarship to pursue a medical degree at the University of Singapore. After graduation, she worked in Singapore before returning to Penang. She spent a year working in the United Kingdom before receiving postgraduate training in gynecological oncology at the Mayo Clinic and at University of California, Irvine in the United States. Dr. Gan joined Gleneagles Penang in 1990 and started the IVF lab in year 2000. She is active in community work, being an executive member of Penang FADA, as well as the Women's Welfare Council. Without much ado, let's have Dr. Gan on stage for her talk titled Tools for Pregnancy. Dr. Gan, the floor is yours.
I'm a gynae, so I will talk about gynae bits. And this is my topic. Tools for pregnancy. Do you think it is easy to have a baby? No. But sometimes you read the newspaper, they say, oh, somebody got raped and then got baby. And then you see pictures of birthday, the man has got 20 children. Sounds easy, right? Then your friend in the office got married and have a baby. Oh, very easy. Or somebody just had a baby and then you say, hey, I went for the wedding only 3 months ago, ma. How come the baby so fast? Oh. All these are exciting thoughts. But what if you cannot have a baby? See, the mood is different. Your brain also, there's a blank. But no worries. Today, we'll try and fulfill some of your anxieties and questions that you may have about pregnancy and fertility. So what is subfertility? I mean, when do you decide, oh, I can't have a baby? Well, you should get worried if you have not been able to have a child after trying for 1 year. Okay, so we have medical definition. Means if you've been having sex with your partner properly for the last 1 year and you cannot conceive, that's a possible problem. And there are two types of fertility. One is primary, meaning you've never had a baby. And second one is a secondary infertility, meaning you've had one child and after that cannot have any more. So what are the causes of infertility? It's a relationship between man and wife, so 40% of it is due to the men, 40% of it is due to the ladies, 10% is a combination of factors for both men and women, and of course, in 10%, we don't know. So doctor also sometimes don't know, okay? Now, is this a medical problem or not? It is, because 1 in 6 couples who are married cannot have the child that they want. So just for statistics, many years ago, 10% of people who are trying to have a child cannot have it, only 10%. Now, it has risen to about double, 15 to 20%. Now, why is that? Well, because last time we see pictures, the grandfather had birthday, wow, the children fill up the whole room. Now, sometimes one also don't have, right? So there is a difference in the statistics now. So is it on the rise? Yes, of course it is. Why is that so? Is it because of promiscuity? Is it because you're too busy? You got married late? Or even after married early, you don't have a child? Or it could be due to stress. Now, as practitioners in this business of trying to have raise a family for you guys, we face certain problems. For example, the topic of infertility is not something you talk about. For example, let's say the doctor says you've got to produce a sperm test, right? Then how's the man going to tell the boss, today at 2 o'clock I have to go to the doctor. Then the boss says, why? You're okay, isn't it? You got operation or what? No. Something like he has to say something and he has to lie. So that is. So the topic is taboo. And secondly, because of this tabooness and sensitivity, you may also sometimes seek advice from the wrong place. But more importantly, it is the fact that denial of your problem. You keep postponing. This month, I'm too busy. Or next month, my husband is overseas. So you make excuses for yourself until it's too late. Okay? And of course, we know that it is a stressful situation for you as a person with this problem. So we also try to reduce the stress for you. So the technology has improved to such a stage where you come to see the doctor less frequent, medicines are quietly taken, and less frequent. So it is, we try to reduce the stress for the people having this problem. Well, just in case you're wondering whether you qualify to be infertile or not, there are certain things you must know about yourself first. What makes you think that you will be infertile? Number one, as a matter of information, you will just to know that even if two couples are perfect in every way and they have sex at the perfect time, still cannot get pregnant. It's only 25% of chance of getting pregnancy at the particular time. So it's not easy, under ideal conditions, okay? And you will know that as you grow older, your egg changes. After 30 years old, the quality change. After 35 years old, the number drops, okay? So that's why the timing is very important. You do not come at a time when everything is gone and wasted and died. For your information also, our ovary is a storehouse. Once you're born, the thing is stored there. It doesn't keep on growing as you grow old, okay? So when you're born, you have 5 million eggs. That's a lot. Now when you're reaching puberty, become 2 million. See, become half already. Now when you're menopause, there's nothing left, okay? But that's the way nature is, all right? If you know this, then you know how to plan your life, isn't it? Right. Okay, now have a look at ourselves again. Are you at risk of this medical problem? Look at your weight. If you're too plump or too thin, it will compromise your fertility. And of course, your age. Both men and women, if you're old, you also affect your reproductive ability. And of course, if you have some sicknesses like infection in the pelvic area, if you've had surgery in the pelvic area, all right, if you have endometriosis, okay, and if you have a bad lifestyle like smoking, taking a lot of alcohol, it will affect your fertility. How about the men? Of course, Dr. John will be speaking about the men, so I will not talk about male problems. I will concentrate on the female. What are the problems that the female can have that will impair her fertility? Number one is her age. We've mentioned that. Hormonal disorders, the tubes may be blocked, polycystic ovary, endometriosis. These are some things I will perhaps talk a bit more later on. So what can be the lady's problem? The egg needs to grow and it needs to ripen properly at the correct time. So having this sequence of natural event is very important, and this can be disturbed at any one time. So you need the right hormonal balance for conception. And I remembered I recently had a patient about quite elderly, and she suddenly had a baby after many years of marriage. And you know why? Because maybe about 6 or 7 months ago, she was a healthy lady, she had a boil in her buttock. You know, we call it an abscess in the buttock. So she saw some other doctors, they did operation and so on. Because of the infection in the buttock, her abscess, we found that she's diabetic. That's all. She doesn't know. But because we treated the diabetes, she has a baby. Very easy, huh? Okay. Very easy. For her, it's very easy after the treatment of the diabetes. Okay, polycystic ovary. This is rather complex endocrine problem, but basically it is a woman whose hormones are disturbed and she cannot produce egg at the right time, okay? Or she doesn't produce egg at all, it's so unpredictable. And ovaries are very thick, the wall is very thick, the eggs can't come out. And she's also prone to diabetes and cancer as well. Okay, fallopian tube. A fallopian tube is the connection between the womb and the ovary. It's a very important road. If this road, we have two roads, one on left and right. If the road is blocked, it is blocked. There's nothing that can go through. You will never have a baby the natural way. So the tubes can be blocked, right? So this is the uterus, and this is a normal tube. The normal tube is the size of a toothpick. Now this other one is very big. Okay, it's swollen because it's blocked. So we have one road blocked here, this one is open lah. Okay. Okay, salpingitis is a medical term. It simply means the fallopian tubes are inflamed. But how do you know you have inflamed fallopian tubes? Pain. You have pain in the lower abdomen. And we know that in those women who are infertile, 1/3 of the problem is due to the tubes. And these tubes can be damaged by infection years ago, even before she got married. It could also be blocked by an ectopic pregnancy, which she had some time ago. In other words, if she had a baby that was in this fallopian tube and it damaged the tube, that tube is blocked. Or the tube can be damaged due to adhesions as a result of surgery, appendix surgery, or infection. Oh, okay. And also malformation of the fallopian tubes. Malformation is something that you're born with. This is present very infrequently, but 5 in 100 infertile women will have this problem. And these are the problems that can be abnormal in the uterus. This one is a picture of the uterus there with the white black thing there. This is a fibroid inside the uterus. So this fibroid is sharing the room with the baby. So if it's there, it affects the baby's growth, right? And of course, the other picture is the uterus being abnormal. The sides are a bit wonky with some edges are irregular. Again, the uterus or the room where the baby is supposed to stay is abnormal, so difficult for the baby to stay. Oh, endometriosis. We mentioned a bit earlier about endometriosis. It's a very common condition. And how do you know you have it? Pain. Pain, usually during the period. And it is a condition where the menstrual blood comes out, but it also goes back. It reverses back along the fallopian tube into the cavity of the abdomen. And when it goes there, it stays there, it irritates the area around it, causing inflammation and adhesions to the fallopian tube. So you can have painful periods or even painful intercourse. Or sometimes no pain at all. We have no idea. But you can still have endometriosis without pain. And of course, there are some abnormalities which came on over the years, which can affect your fertility. And one of them is a uterine polyps. These are little fleshy growths which sits in the uterus. And of course, fibroids. These are growths as well, affecting the uterus. And therefore, the baby cannot implant properly. Right. Now that we know what it is, so we have to now find out it's a doctor's job to evaluate and diagnose this problem. When we see you, a few questions go through our mind. We need to think about the woman. Does she have an ovulatory problem? Is her eggs able to meet with the sperm? Is the baby able to grow and grow properly? And with these questions in mind, we will then work our treatment accordingly. So, as we say, we try to reduce the stress for this kind of treatment. But the first thing we do is, like all practitioners, we take a proper history, we do examination, both men and women, and then we start with simple tests. And this test can progress on to more complicated tests. Right. What are the basic evaluation procedures that are available? These are medical terms. Basically, we need to look at the womb, and we need to look at the fallopian tube. And to look at the womb, all these, we can do it in so many ways. We can use X-rays using for example, the hysterosalpingogram. It's a test you do inside the X-ray department. The doctor puts some dye into the uterus, and we're able to see the lining, the outline, and the shape of the uterus. And this is not an operation, so it is not invasive. It's very safe, can be done as an outpatient. And this is a picture of what we see. On this one here is the uterus. This is a picture of the hysterosalpingogram. This is a picture of the uterus, and these are the fallopian tubes. You see that it's very thin on both sides, and the uterus shape looks quite normal. This one is abnormal because one side, the white part is bigger than this one. This is a normal fallopian tube, which means that sperm can go through here. But this one is bloated and enlarged because it is blocked. So there's no way the sperm can go through, neither can the egg go through to form the baby. Certain more complicated investigations we can do include a hysteroscopy, meaning we put a camera, instead of using X-rays, put a camera inside the womb and to have a look using direct vision. And this also can be done as a simple procedure. And of course, we can go to more complicated things like laparoscopy. This is a bigger operation, and for this to occur, you have to go through the navel. So there are some puncture wounds in the stomach. A bit more complicated, but you also can see a lot of things, all right? There are some new advances. Now, this picture here is a 3D picture of the baby. We are all familiar with this nowadays. We can use the same 3D for the womb as well. It gives you a different picture of the uterus. I would just like to talk a bit more about newer and further tools that we can use to help you have a baby. First, look at your weight. That is something you can do. You don't have to come to see us. Please get your correct weight. Because if you don't, we cannot. We are struggling. The medicines we give you don't work. The babies don't grow, and you're wasting everybody's time. So please get your weight correct. And personal habits, so important. Now, diet is fine, but if you're dieting too much and too thin, you cannot have a baby. That's it, right? And exercise too. Now, exercise is important, but the type of exercise you do sometimes may affect your fertility as well. At the last meeting last week in Kuala Lumpur, at the Aspire meeting, there was a study done in Singapore about people trying to have a baby. And they found that those who are trying to have a baby, the first thing they do, they stop exercise. Well, yes and no for that. But some exercises, for example, they exercise the bicycle for the men. It's not so good because it affects the testicles. And after the exercise, you go into the spa, all hot and heated up. Also not very good, okay? Lifestyle. Lifestyle. Sometimes, the husband is in one continent, the wife is in the other continent. Very hard to have a baby, Smoking is bad. Dr. John will tell you this, the sperm just die. Alcohol, now shower. Sperm don't like to be too hot. Am I correct, Dr. John? Yeah, he agrees. So if your husband takes hotter showers, soak in a long bath, and go to the spa and all, it's not going to work. He's going to kill the sperms, right? And lubricants, my God, the lubricants people use. Because you're going to have a baby, right? Then they're a bit tense. And then ovulation time, call the husband, hey, tonight, like that. Then the husband, anyway, whatever stress is coming. Then some more you're stressed, he's stressed, all stressed. So, okay, use lubricant. Go and Google, KY jelly, boleh. Or olive oil, coconut oil also can, virgin oil also can. Now, it affects the sperm. Okay? So don't just, I know you're desperate, trying to get the timing correct. That's it, But please, just be aware of this lubricant thing. Now, if you've done all this, you've read the Google, you've gone to the pharmacy, buy the whatever cream or whatever they say, and they still don't work, then you come and see us. Okay? It's fair now. So we try to help. And the techniques we have include, very simply, intrauterine insemination. Very easy, outpatient technique. We get the timing correct, and then we put the sperm in. Sometimes we also activate the sperms for certain borderline cases. So, and if this doesn't work, or there are more serious problems, then we go on to what we call assisted reproduction. This is a term meaning more fancy. That means you go to IVF and all the things that are associated with IVF, which means you need a laboratory. You need the scientist, you need the embryologist, you need high-tech stuff. But it's good. It helps a lot of people, right? I just want to mention very briefly. Do I have time? 1 more minute, oh God. Okay, right, a bit about donor sperm. Now, sometimes you need donor sperms, okay, because the sperm is not available. And donor egg and surrogacy. Just mention very briefly surrogacy. Again, last weekend we had this update on fertility issues, and we talk about surrogacy. Surrogacy means your baby is resting in somebody's womb for a while, okay? In the developing world, like Thailand, India, so-called, they're trying to ban this, and they have tried to do so successfully, legally. But this lady who gave a lecture says that surrogacy has been going on in America. It's been going on in Israel, and they are doing it legally, and nobody is complaining. But why suddenly they want to put a stop to this surrogacy in India, in Thailand? Or some NGO, not our NGO. Some NGOs, they're abusing women, taking advantage of them, this and that, this and that. But we found out that the women who offer themselves for surrogacy are women who need the money. It's no big deal. They need the money because their family needs the money. Maybe the husband just had an accident, he has children, need to go to school. And we have seen stories of women with this money they earned, made the family go forward. With the money she earned as a surrogate mother, she supported the education of her children. And some of them have actually become doctors in the process. So there we are, an issue perhaps for us all to think about whether it's useful or not, okay? Just finishing with a few slides on the new developments, very new. Laboratory. We talked about laboratory in assisted reproduction. Because the industry is getting into the business, so they're putting fancy equipment. Now you can put the baby inside the test tube and look from afar. You can even go to holiday and look on your handphone. Oh, this baby is growing. You take this one no good. You can choose the egg. When you're not in the laboratory, this is called time-lapse machine. Yeah. And genetics. Genetics are now come back into the picture. as you know, we're able to do the genetics on the embryo, all right? Male, female, and other diseases like thalassemia, for example. And lastly, very importantly, metabolism. Metabolism means they understand how the body grows. And we have people specializing in ovary metabolism. The whole career, they only study the ovary. How it functions, hormones and everything. And last year, there was a Nobel Prize given for studies on mitochondria, which is a little organ inside the cell. A Nobel Prize. Don't forget that. It has such important implications to fertility management because the mitochondria has not been studied in great detail. You can use the mitochondria to activate the old ovary. You can take some things to prevent the mitochondria from dying. And after your ovary die already, you can take some medicine to bring the ovary up again. It's called in vitro activation. Now that's very new and very exciting. So there we are. Okay, that concludes my talk on infertility. Thank you.
Dr. Gan, thank you for the informative talk on infertility and its treatment. Ladies and gentlemen, please note that there is a question and answer session before lunch if you have any questions for Dr. Gan or any of our subsequent speakers. Our next speaker is Dr. John Ooi Chong Chien, who will be delivering a talk titled The Way to a Woman's Womb. He is a consultant general surgeon and urologist at Gleneagles, Penang. Dr. John Ooi Chong Chien graduated from University of Malaya in 1999. He obtained his postgraduate specialist as a surgeon from the Royal College of Surgeons of Edinburgh in 2003 and Masters of Surgery from University of Malaya in 2007. Dr. John Ooi obtained his fellowship of Royal College of Surgeons Urology and was elected Fellow of the Royal College of Physicians and Surgeons of Glasgow in 2011. He then spent a year in Adelaide, Australia in 2012 for a fellowship in uro-oncology. Dr. John Ooi is registered with the Malaysian National Specialist Register and a certified member of the Board of Urology Malaysia. Dr. John Ooi, the floor is yours.
Okay. Good morning, everyone. My name is Dr. John, and I'm the urologist here in Gleneagles. So you will ask me what is my role in infertility. So as you know, it takes two to tango. So Dr. Gan has already explained how she has to prepare the womb for the baby, okay? My job is to get the soldier to that womb, okay? All right, so as you can see from this slide, all we need is only one sperm to get a baby, all right? God has given us millions and millions of sperm, 20 millions, 120 millions. But then you ask, so many sperm, how come one cannot reach the womb, all right? So I'm here to explain to you what are the possible factors that can cause the sperm not able to reach the womb. Okay, so male infertility. The actual definition of male infertility is when the woman is normal and everything lies solely on the male's problem, okay? So how common is that? It affects actually 7% of male. That means if I were to take 100 men in this room, where there is no 100 men in this room, 7 of them will have some issues, not to say no sperm, but have issues by getting the sperm to the womb, all right? Okay? As you know, I mean, most of the time when, you go for events, for Chinese New Year, You know, the first thing everybody will be looking at younger married couples are, hey, when is your children coming? When is your children coming? And nobody actually looks at the male, right? They always look at the female and looking like, hey, are you looking at the female and asking, are they eating right? You know, they will give a lot of soup, a lot of herbs, you know, and everybody is just trying to look at the woman and saying that what's wrong with you. So this is how our community usually perceive. So when they have no baby, the first person they look at is at the female. So the poor female is always, okay, I'll stand there. So the poor female is always blamed for not being able to have children for their husband or grandchildren for their grandparents. Am I right? Okay, so is that a fact or a taboo? Of course we know it's a taboo, otherwise I wouldn't be standing here. Okay? So despite all of us thinking that men are very, very strong, but in terms of fertility, we are equal. Meaning men also contribute the same percentage of reasons why a couple cannot get pregnant. Okay? So for the men here, actually, we are actually weaker than the women, although we may appear strong. If you were to look, not working. Okay, so actually men die 7 years younger than female. Okay, and men, if you were to look at the statistics of heart disease, cancers, stroke, we actually die quicker than female. We also suffer more serious chronic disease, such as diabetes, heart problems, compared to female. Okay? And also, we are more likely to die twice more than female. And of course, if you were to look generally, men uses more drugs, gamblers. We drink a little bit more alcohol than female. And also, we do smoke more. So as you can see in this picture, the strong man in front there smoking, is definitely weaker than the female behind. Okay? And whatever you want to say about female being bad drivers, unfortunately, the statistics for road traffic accidents states that 8 of 10 accidents are actually caused by men. Okay, and more importantly, actually, male actually avoid doctors. As you can see in this room, of 100 people, how many men came? Okay, you can see, almost 90% of people are female, because female, just generally, they're a bit more concerned about their health. Men generally feels that I feel very, very well. There isn't a need for me to go and see a doctor. Most men go to the doctor only when they are seriously sick. That means we see more men in the emergency room, but we rarely see men walking into our clinic to see doctors, all right? Whereas for females, it's different. By the time you're 25, you're 27, you can't get pregnant, everybody will ask you, hey, go and see a doctor. Must be something wrong with you. Must be something wrong with you. So generally, females visit the doctor much earlier than males, and they are diagnosed with diseases more earlier than males. But the thing that gets men attention is always when there's something to do with their vital organs, all right? And also, or the other thing is when the female partner tell the man to go to see a doctor, all right? So, comes back to the original talk. So, how common is male infertility? So, it's actually like in what Dr. Gan feels, her statistic shows that for men is probably around 40%. Of course, I'm a male. I feel that it's only 25%. But anyway, whatever said and done, looking at the statistics here, the percentage is almost similar, all right? So we find that the female factors contribute 25%, male factors contribute equally, and the combination of both is around 50%. So what can be the causes of male infertility? That means the sperm from the testes going into the female's womb, all right? The first one is, of course, the inability to produce sperm. So this is at the factory level, which is the testes. So I will explain to you later what are the things that can affect sperm production. Of course, for the second cause is the sperm, although it's produced in the testes, it can't get out of the testes, okay? So these are like problems with the tubes. The third one that can affect infertility in general is the lifestyle. So that plays a bit, very, very important. Almost 50% of the causes of infertility we see in men are just due to general health and lifestyle and also environmental exposures. So the environmental exposures are like smoking, alcohol, drugs, and medications. Okay, so this is just a picture to just show how sperm is produced and how it's delivered. In order for the sperm to be produced, of course, we will need some hormones first. And these hormones actually come from the pituitary. And the pituitary will normally stimulate the testes to produce sperm. And this sperm has to travel through what we call the vas deferens and go behind to the seminal vesicles and get ejaculated out from the prostate all the way through the urethra into the women, okay, into the female reproductive system. So anywhere this area, something can go wrong. It's either the testes may not be able to produce the sperm, or there are some blockages along this area. Okay? So this is just a picture of our testes. So we can see that in our testes there are a lot of cells, seminiferous tubules, and these seminiferous tubules actually produce sperm, and it goes into what we call ducts, and is kept inside this rete testis, and it actually goes into the epididymis. So from a sperm from the beginning till its matured state, it's said to take around 70 days, all right? Sperm will normally start forming in the testes, then it will stay in the epididymis, and the epididymis is like a gym, okay? So they will gather their strength, their motility, and their strength to move in the epididymis. And this actually takes around 2 to 10 days. Then it waits there, and when sexual intercourse is done, the sperm will swim all the way to the seminal vesicles. I'll just go back the slide. So it will swim all the way, it will swim all the way to the seminal vesicles, whereby in the seminal vesicles, actually there is prostatic fluid. So the ejaculate that we ejaculate is not all just sperm. It's a combination of sperm and prostate fluid. Okay? And our sperm and the prostate fluid will go all the way out and enter the female. Okay, so when we say that there is some problem with the sperm, what is the problem? Of course, some people have no sperm at all. Some people just have decreased number of sperms. Some people have sperm, but the sperm, every single sperm is not normal. All right, that means abnormal sperm. Some people have normal sperms, but the sperms cannot swim. Some of the sperms just dance around and they're not moving anywhere. Some of the sperms, they move, but they move in the wrong direction. What we are interested at is the sperms that can actually swim straight and fast, and then go at the right direction. Okay? So what are the things that can cause decrease in sperm production? So, the medical causes are, of course, some people, they have undescended testes. We have seen patients before who never realized that they actually have only one or maybe no testicles down there, because they have been born with it and they thought that it was normal. So when your testicles is high up or within the body, it is too hot. You are right. Dr. Gan did mention that our testes, the reason why it's outside our body, is so that our testis is cool, around anything less than 34 degrees Celsius. When it goes into our body, it's 37 degrees Celsius. That is not good. And of course, if we were to go to like sauna or spa, we increase to 40 degrees Celsius, even worse. Okay? So it will make our sperm sleep, and it will make our sperms lazy. And also, it will cause the cells to produce less sperm. Other things that we do find is also what we call varicocele. Varicocele is a condition whereby some people just have a little bit more blood vessels surrounding the testis. So because when you have more blood vessels surrounding the testis, of course the testis will be a bit heated up. Okay? And when we find that patients have less sperms, we actually do hormonal tests, and we find that some patients may have also decreased hormone. Other things that can affect sperm production are anti-sperm antibodies. These are antibodies that are produced by oneself. It can be because of infection. It can be because of a previous operation to the other testes. And all these things can cause anti-sperm antibodies, and your own antibodies actually attack your own sperm. All right? And of course, lastly is infection. Because nowadays with a lot of extracurricular activities, we do actually see males that come in with sexually transmitted disease, and all these sexually transmitted disease are actually very, very harmful to the sperm. Okay, the second one, so that I was talking about is the testis proper. Okay, there are other people who have good sperm production, but the sperm cannot come out. Okay, so these are patients who maybe have other things like erectile dysfunction, retarded ejaculation. There are some people who just can't ejaculate. Or some people may have also retrograde ejaculation. Retrograde ejaculation is whereby instead of the sperm going forward, it goes back into the bladder. This we see more in older men, whereby sometimes there is a bit of problem with delivery of the sperms. Okay. Then other causes of blockage are, of course, blockage of the vas. Remember, I showed you earlier. So this part, any part of this tube can be blocked. And there are also patients who have hypospadias, meaning that the meatus, the whole of the penis is not actually in front. It is located at the bottom. So every time they ejaculate or they urine, they think that they are shooting forward, but actually they are shooting downwards. Okay? Like I said, among all the 100% of cases that we see, 40% of them may have actual sperm production issues. 10% of people can be due to true blockages. The other 50% are just more due to lifestyle habits and environmental exposures. So the lifestyle habits are like obesity. It's the same. Men and female are the same. We need to get our BMI down so that we have good hormone balance, we have good testosterone levels, and therefore we can produce good sperms, enough in numbers, good quality sperms, and sperms that can swim straight and fast. Okay? So these are the things that nowadays a lot of people, due to stress, either family, work, so all these have a bit of impairment in the quality of their sperms. Age, of course, is a problem, but it's not so much of a problem compared to females. For males, generally, we say that above 70 years old, sometimes there can be some problem with the sperm quality and the morphology, that means the shape of the sperm. That is something to do with genetics, all right? Okay, so the things that, so other things that can affect the sperm is if people have normal sperms, and also have normal delivery, these things, that means brought about by the men themselves. They go to take alcohol, smoking, drugs, and of course overheating the testicles. So these are like sauna, spa, all of these. We actually take a good history and ask patients not to go for heating, for spa. So smoking actually is one of the worst things that somebody can take. It actually decreases all three, the sperm count, the movement, and also the shape. And also, if patients were to go for, let's say, IVF, it also impairs the success of the IVF. And another group of patients we see are also young patients who actually abuse steroids. So these are healthy males who come and they are actually on testosterone therapies. And this is for maybe their bodybuilding. So we know for a fact that testosterone actually decreases sperm count. So what do we do as doctors? So as doctors, normally when we see a patient, we take a good history. We just make sure that the patient actually is infertile, which is the couple has not have any baby for 1 year. Okay. The second thing we look into is to make sure that they do not have any environmental toxins such as smoking, alcohol, drugs, steroids. And after that, we will go for physical examination. So during examination, we'll actually have a feel of the testes to look at the size, to have a look at the cord to make sure that it's there. And if everything is normal, the main thing that we do is two things. One is we take a urine test to make sure that there's no infection. And the second thing is we actually take semen analysis. We will advise the patient how to collect their semen and also do some hormonal tests if the semen analysis is abnormal. So this is what we look at the semen analysis. And it is not read by a radiologist, but it is actually read by an embryologist. Okay? Okay. So the thing that we actually look at during the semen analysis is to look for the exact number. We look for the morphology, which is the shape of the sperm. And we also look at the motility. So there are a lot of factors we look at. These are the numbers, but then we would normally explain to you during our consultation. Okay. So is there any medical treatment? I'm just going to go quickly. Okay. Is there any medical treatment for infertility? Actually, there are a lot of supplements out there, but actually we don't really encourage, okay, because we have to find the root of the problem. The only medical treatment that normally we may start if there are any hormonal imbalance, okay? So like we said, there are some people who have problem, lack of hormone at the pituitary, which makes it difficult for the testes to produce sperm. So these are the only true medical therapy. Of course, in terms of surgical, since I'm a surgeon, the operations that we do these are varicocele. So for you men out there, you better have a look down there and see whether you have these dilated veins or not. So if patients have dilated veins, it's actually like a bag of worms. So for these kind of patients, we actually remove the bag of worms so that the testes will be cooler and can maybe produce better sperms. And of course, if there's nothing else, we also do surgery to see whether there's any production of sperm. So these are for patients whereby when we do the semen analysis and there is no sperm at all coming out. So we need to know whether the factory is functioning or not. So in this case, we sometimes do under general anesthesia, try to take some sperm out from the epidermis, or we take out from the testes. And if let's say we really find no sperms, we actually do a biopsy of the testicular tissue. And the pathologist will be able to tell us whether there are any cells in the testis that can produce sperms. Because in our testes, we have two kinds of cells, Sertoli cells and Leydig cells. Leydig cells produce hormone, Sertoli cells produce sperm. So we actually look at the Sertoli cells and see whether they are healthy Sertoli cells or not. Okay? And of course, whenever we do this kind of surgery, we always make sure that we have a sperm bank, because just in case we get some sperm, whatever little sperm, we will quickly keep it in the sperm bank, all right, for future use, okay? So this is my last slide. So a lot of people will definitely ask me, doctor, is there anything that I can do, anything I can eat for my sperm? Huh? Everything is all about food. But before we go to food, like we always said, like for the females, we exercise first. We make sure that we control our weight. We get our BMI down below 35, okay? This is what the patient can do. And of course, external factors like if you are smoking, drinking, taking some recreational drugs, or patients who are on testosterone, we tell them to stop all this. And we actually ask them to do this lifestyle modification for 3 to 6 months and come back to us and repeat the sperm test. These are for patients who have sperm, but maybe not so good quality sperms, all right? And of course, there are a lot of studies still carried out for all these kind of supplements. Some of them do actually work. So they are like vitamin C, vitamin E, zinc, selenium, coenzyme Q10, and L-arginine carnitine. Right? Okay, so in summary, basically, male infertility should be treated in a specialized unit. That means somewhere that has urologists. And as you know, that we have new methods and advanced methods to help patients and couples to father or to mother a child. And more importantly, in this 10% of people whom I see, there's actually a surgical treatable cause. So this is what we want to tell patients. So out of 100%, 50% can be sorted out by the patients themselves. 40% may need a bit of help with medication. 10% may require surgery. Okay? And lastly, male, although infertile, can be a father. All right? So that's all my talk for today.
Dr. John Uy, thank you for your enlightening talk. Now, I would like to call upon our third speaker, Ms. Shireen N. Selvaraja, is the consultant child development psychologist at Glen Eagles, Penang. Ms. Shireen N. Selvaraja is by profession a child developmental psychologist and has been in the field of child developmental psychology for the past 15 years. She's a director at a private center for children with special needs in Penang. She is also an adjunct senior lecturer at Penang Medical College. Ms. Selvaraja completed her Bachelor of Science degree from the University of Leeds and obtained her Master's in Applied Developmental Psychology from the University of Hertfordshire. She's a member of the Psychological Corporation UK and international affiliate member of the American Psychological Association. Her area of interest is in children with learning disabilities, behavioral issues, and developmental disorders. She has presented at numerous international conferences and public seminars. I would like to invite Ms. Selvaraja up the stage for her talk titled The Psychological Journey of Being a Parent. Ms. Selvaraja, the microphone is yours.
Hi, good morning, everybody. Okay, so today I would like to share a little bit on how it is like to become parents and to go through this whole journey of being parents. Okay, so now, initially, as we have heard Dr. Gan and Dr. John spoke about infertility. Now, in the society that we live in nowadays, infertility seems to be a little bit of a stigma. You know, women or even men don't like to talk about it. And don't like to admit sometimes that they may have some difficulties in having a baby. But my question is why? You know, why is it being looked as a stigma? Why is it that, you know, people shun away from this whole issue? You know, does it make a woman lesser of a woman if she is not a mother? Or does it make a woman, a mother, less of a mother if the baby is not biologically hers? You know, so in this current day and age that we live in, there are many ways of becoming a mother, right? But sometimes women or even men, when they are faced with difficulty or they think that, you know, oh, I cannot have the baby naturally, and they battle with this whole issue of infertility. And emotionally, they go through a real roller coaster ride. Okay, so we see a lot of women or men as well who need to battle with this whole issue of depression. They feel low, they feel you know, very upset. They have anxieties, you know, anxious that, you know, oh, I cannot conceive, I cannot have a baby. And this is a chicken and egg thing, you know. We realize that the more upset you get, the more difficult it is for you to, you know, conceive naturally. And you go through a lot of stress. You experience a lot of difficulties. Okay, and this as well can cause, again, you having more difficulties conceiving. There's always this problem with guilt, right? So you feel that it is your fault. You feel guilty that, you know, you cannot, you know, satisfy your partner in a sense to become parents naturally. There's a lot of self-blame. You feel that, oh, you know, it is my fault. You know, I can't do this. There's something wrong with me. You know, and little do you know, it could be actually your partner that could have some difficulty. Okay? And there's also this issue with shame. You know, when men or women more so, when you're among your girlfriends, right, and you all are talking and sharing about, you know, oh, you know, this girl got married last year and already got 2 children, and you wonder, you know, how's that even possible? You know, but, you know, so there's a lot of shame when you are speaking with your peers or with your friends, and you feel embarrassed. And of course, most importantly, we see there are a lot of effects, you know, when couples, the dynamics of couple relationship are always affected, you know, because one is not understanding how the other feels, or you know, sometimes you tend to also, you know, point the finger and say that, you know, it's you, you know, why don't you go and do something about it, or, you know. So there's a lot of stress within the couple relationship itself. And all this can lead to more and more of a problem. Okay, so what would you do when you are in a situation like this? So I always encourage, you know, my clients and say that whenever you have a problem, especially if it's a problem between a couple, always have open communication with your partner. Discuss the issue. Okay, sometimes you can also, there are some peer-led support groups that you want to join, you know, because then you get to share and you don't feel like you are alone in this whole battling situation. So And it is fine for you to also allow yourself to grieve, to feel sad, to feel upset that, things are not working out right. It's fine to feel that way. And give yourself that time to go through the whole grieving process well. Because eventually it should lead to acceptance. Okay, with accepting, and then, I think it goes around a few times. You move on. Okay, and when you move on is when then you will take the next step in consulting a doctor or a gynae or, a urologist if you're a man, to help yourself try to overcome this difficulty. Only through acceptance. Okay, so say now, everything's been accepted, you and your partner has decided, okay, let's take the next step. Let's go and see Dr. Gunn or go and see Dr. John. Let's go and get some consultation and see what's going to happen. Okay, so you speak, you go through things, and then, hey, you can get pregnant. It's for some, in some means, or even if it's not naturally, there are other options, which we will talk about later in the day-to-day, where, there's always this option of adoption. So you eventually are successful and can become parents. Okay, so becoming parents is a joy, right? But it does come with challenges as well. Okay, but one thing to remember is that parenting is a skill that you have to learn over time. Nobody gives you a manual and says, okay, here you go, you're going to become parents, you read this, you will be the perfect parent. It doesn't work that way. Okay, it takes time, it takes confidence in yourself, it takes a lot of practice. Okay, so going through motherhood, is a very challenging job. Right? I'm sure there are quite a lot of numbers of mothers here in the room that will agree with me. And sometimes if you've gone through a difficult experience in becoming a mother, sometimes you feel that this is not what you expect it to be like. Hey, my friends say, well, being a mother is so nice. You can, you love your child so much and, you feel wonderful. But then you realize, hey, I'm not feeling that way. Is there something wrong with me? And then you start to blame yourself and you believe that motherhood is not for you. Okay, but it is always important to remember that no one is perfect. No one can be the perfect mother. Okay, and sometimes you feel that, you're doing things wrong because your baby cannot settle, is crying all the time. Why can't I just, have a nice, baby sleep, I enjoy myself, baby wake up, I feed the baby, but, hey, it's not working like that, right? Sometimes it might not be you. It might not be you as a mother that's not doing things right. We got to see sometimes the temperament of babies. Okay, so some babies are easier to soothe or to settle compared to others. Okay, so it might not necessarily be that you are doing something wrong. Yeah, so overall, it is an enormously challenging job, but can be very, very rewarding at the same time. Okay, now, we always forget fathers, sometimes in this whole parenting thing, but they play an equally important role as parents. Okay, and it's always, as a father, it's very important for you to value your role as a father and be as involved as you can from the very beginning. Okay, so your child and your partner needs you in different ways. So you have to be readily available for them. Yeah, and find the time to contribute greatly to this relationship building process. So becoming parents does create a lot of changes in the whole dynamics of couple. You're no longer two, now you're three or maybe sometimes more than three, right? So we see that, and in the process of becoming parents, so if you successfully manage to get pregnant and now you are going to be carrying a baby, there are a number of emotions that you will go through during your pregnancy. And if you've managed to say, okay, you've adopted a child and now you have a child of your own, you will also go through a number of emotions after pregnancy. The key thing here to remember is to be emotionally stable is very, very important. during pregnancy, all throughout the stage, and after delivery. Okay, so it will really optimize the health of you and your baby. Okay, now one thing to remember is this whole issue of interaction. You know, sometimes upon delivery, you know, mothers are not in a state where they feel that they want to even have any connection with their baby. There are some mothers who feel that way. You know, and they feel that, oh, I just need to feed the baby, change the diapers, put it to sleep, and then it's fine, you know, I carry on with my own work, you know. So you're just providing for the baby's needs. But very importantly, and in most cases, a lot of mothers forget this whole aspect of interaction. Okay, which is very, very important, as it helps shape the way a baby thinks, feels, and behaves all throughout throughout the child's life. Yeah, so it helps to develop and build close relationships, secure attachments, and bonds between the parent and the child. Okay, so when you are only able to provide in the best possible situation when you are emotionally happy and contented. Yeah, so as this will, you know, help with the overall developing the child's development physically, mentally, emotionally, and in all aspects. Yeah, so sometimes we feel that, you know, you cannot do this whole thing by yourself, and you need help and you need support. So it is fine to ask for help. In fact, asking for help is one of the big steps forward that you are making. Okay, so the easier you seek help, the sooner your problems can be overcome. Yeah, so these are some common emotional problems that we see mothers face sometimes. You know, in most cases, it is upon delivery. Okay, so one of it is called baby blues, which I think every mother must have gone through it. You know, it's just a matter sometimes, you know, you're feeling a little bit down, you have a bit of mood swings, you know, feel a bit anxious because you don't know, this is a whole new experience for you. And this also happens not only for first-time mothers, but, you know, second, third-time mothers may also experience baby blues. And this kind of feelings probably last for maybe a week or so, you know, maybe maximum about a month after delivery or after you have had a baby. Okay, so just a natural feeling of blue. You know, all of you have Monday blues as well, right, sometimes. So that's just, you know, one day that you feel a little bit down. Now, another problem sometimes we see is some mothers experiencing this issue of adjustment difficulties. Okay, now having to make this change from being a single person to having to care for another person, which is your baby, and you feel very responsible for this child. So this whole adjustment can create a lot of anxiety, a lot of you know, stress within yourself, with your partner. Okay, and then you have this issue with attachment. So there are some mothers who feel that you know, they have difficulties attaching to their baby. And I don't mean in sense of, you know, feeding, you know, where you have to breastfeed and you cannot attach. That's different. This is the emotional attachment. Okay, and they feel that sometimes very withdrawn from their baby. You know, they feel very distant, that, you know, you can't, and then you question yourself, why is it that I cannot, you know, everybody says, oh, you know, when the baby comes, you feel very happy, you will love your baby. But, you know, I'm having this feeling that, you know, this baby is being such a burden to me, and I just want to stay away from it, and I want someone else to care for it. There is this emotions that a lot of mothers go through. There are some extreme cases where mothers have even tried to harm their babies. You know, so you've seen episodes where there are some mothers who, you know, throw their babies, shake their babies, and, you know, and even have, maybe some even has eventually killed their babies as well. So in situations like this, when we realize, you know, so it's best for a mother, if you feel this way, to talk about it, because the sooner you get help in this kind of circumstances, the better it is for you and for your infant. And in most cases, we will take you away from your baby because it is for the security of the child. And we will work with managing the emotions of the mother, while someone may have to care for the baby at the meantime. Yeah. Then we have mothers who may have some anxiety, antenatal anxiety, and antenatal depression or postnatal, right? So where this is an issue, as opposed to the baby blues, now this is at a more severe level, and it is more of a clinical diagnosis here, which means that the anxiety and depression is actually affecting your whole performance as an individual, as a mother, and naturally in the home environment. So with anxiety comes a lot, and depression comes a lot of similar symptoms like, loss of appetite, low mood swings, also difficulties falling asleep. You have a lot of, they experience insomnia, right? So there are a lot of more at a much severe level clinically. Then you have stress reactions after a traumatic delivery. So there are some mothers who may have had experience, a very long delivery, or even this whole experience of getting pregnant and delivering a baby can leave some mothers with what we consider somewhat like a post-traumatic stress. And then the mother stays away and says, I don't want to have any more babies. This is it. So having to deal with situations like this, right? Then you have those who have postpartum psychosis. Now, this is a small percentage of women, about 7% of women experience postpartum psychosis. Not a very common disorder that we see, but this is where mothers start to experience actual psychotic symptoms, which is like hallucination, delusions, and then you feel like, somebody is coming and taking your baby away, or you feel like, there are people watching you, you are hearing voices, right? So you are unable to care for your baby at the best possible setting. So even in situations like this, we will take you away from your baby if you come with symptoms like this, just to ensure the safety of a child. And we work with you as an individual, as a mother, helping you deal with your emotions. Now, so what are some helpful tips I would like to share with you on how you can help keep yourself a little bit emotionally stable throughout this parenting journey that you are going to go through? So I've actually painted quite a grey picture, right? You probably think that, it's horrible, this thing, becoming a parent or becoming a mother or father. But, there are ways to look at it and how you can make it actually better. So firstly, you have to remember, when you have a baby, you're going to deliver a baby, do not expect the baby to fit into your routine. Right? So this baby has come into your world. You will have to work around your baby. Everything works around the baby, which means you have to be willing to give that up. That now your routines have to change. Okay, so you will choose a time as well when you and your partner are a little bit calm and not so distracted, so that you can talk about some changes that you have noticed. So maybe you want to openly discuss these issues with your partner on how maybe, it's even small things like, you are not paying enough attention to me, you're paying all the attention to the baby, and I don't get any more loving from you, things are not the same, right? So it is important to talk about things like this with your partner. Okay, so you have to be understanding and understand each other. Because now, with the baby in the picture, things are not the same, right? You are going to be very tired, you're going to be overly cranky, you're not getting enough sleep, so you're going to take it out on your partner, right? So your partner has to be rather understanding. Sometimes it might be, useful to talk to your friends, like fathers sometimes, men sometimes, you can just discuss this with your workmates a little bit, and then you realize, hey, I kind of have a lot of things in common. Men generally don't like to talk about these kind of things. My clientele, although I normally see children, and in a lot of cases, mothers always bring the child. And then there are quite a number of cases where also fathers come along, and I really appreciate it when fathers come along and bringing their child along if they feel that their child has, I see mostly children, but, which means men generally try to stay away from all these kind of issues. So sometimes even talking to a friend might be very difficult, so they feel a bit more comfortable talking to professionals. But then you realize, you have a lot of things in common when you discuss these things with some of your mates. Okay, so as a mother, and most of the time you will be the main caregiver for a baby. But once in a while, like I told you, allow the father to come in and play this role as a father. You have to give him credit for it. And a lot of times, we mothers tend to want to monopolize and we want to take care of the baby. And then we tell the dad, you stay away, you don't know what you're doing. I know I'm the mom, I know what I'm doing. But then little do you realize sometimes they can do a pretty good job. And even though sometimes they may do things a little bit differently from you, that doesn't mean that they're doing it wrongly. They may have a different approach to things. And sometimes it may actually work out better for the baby and for yourself. Okay, so at least, I've got just a little bit more. This is my last slide. Okay, so sometimes in a day, it's important to just spend a little bit of time to think about how things are going on in the day, right? You may even want to give your partner a little bit of a break. So you want to tell your wife, okay, I will take the baby for 15 minutes or half an hour. You just go and have a nice long shower. Or you want to go meet up with your friends and have tea or coffee, So just give a little bit of space. Sometimes we need that, yeah? And it's important to be patient and supportive as well with each other. So this whole adjustment from partnership to a family takes time. Okay, so again, don't forget the couple, don't forget your partner, so plan some couple time. So nurturing your relationship with each other is very, very important. So just to sum up a little bit, although no matter what I've said, that how, this whole journey becoming parents can be rather emotional and challenging, but it is the most rewarding job that you can have, being parents. Okay, looking at the sparkle in your child's eyes, I'm speaking as a parent myself. Okay, and when your child comes and tells you, hey mommy, I love you so much, or you're my best friend, things like that makes it all just very worthwhile. Okay, so go ahead and become parents. Thank you.
Thank you, Ms. Selvaraja. That was a fascinating topic which you have touched on. Don't you all agree? How are all of you finding the talks? We have more speakers who are excited to share with you their knowledge. There's one more speaker who I will invite on stage before the question and answer session. Without any delay, let me introduce our next speaker, Dr. Chow Ting Soo, who is the consultant physician for infectious diseases at Hospital Pulau Pinang and Glen Eagles, Penang. Dr. Chow Ting Soo is a member of the Royal College of Physicians, UK, and subspecializing in infectious diseases in the Ministry of Health, Malaysia. She obtained training in infectious diseases and clinical microbiology at St. Vincent Hospital, Sydney, Australia. She serves on the working committees for clinical practice guidelines for HIV-infected pregnant ladies and clinical practice guidelines in dengue management, and is a committee member for Pandemic Influenza Preparedness Plan for Penang. Dr. Chow has given many talks, including at the National AIDS Congress and International Infectious Disease Forum. She has participated in a number of clinical research trials and was published in international peer-reviewed journals. Without much ado, I would like to invite Dr. Chow to begin her talk titled Pregnancy Despite the Odds.
Thank you. Give me this platform today to share with you something I hold very near to me, that, I am an infectious disease person. So you'll be wondering, why am I talking in a pregnancy area, right? So a lot of our clients or patients to-be do not know that when they are diagnosed to have blood-borne viruses in their blood, they can actually proceed to go on to become a parent. And a few of the cases that I know actually, very unfortunately have to end their pregnancy without even consulting a consultant who knows these things better. So this is a platform for me to pass the message to the public that if you know anyone or you yourself had been infected with blood-borne viruses, you may actually have the chance to become a parent, okay? So that is why the topic is pregnancy despite all odds, okay? How am I going to move this? Okay. So I probably would want to tell you that what is the blood-borne viruses that I'm talking about. Of course, you have hepatitis B, hepatitis C, and human immunodeficiency virus, HIV. So a lot of people would not know that in which condition that if you are or your friends have been infected with these 3 viruses, do you think that they can proceed to become parents? And if so, if yes, how can we, make it safe for the pregnancy and make it safe for the outcome for the future newborn or the baby? Because that blood-borne viruses can pass the virus from the mother to the baby. Okay? So now I go into HIV because a lot of people would think that among all these 3 viruses, hepatitis B, hepatitis C, HIV, a lot of public would be very afraid about HIV. Not only public, our nurses, our healthcare providers, they are all very worried about HIV and never think about hepatitis B and C. Of all after this topic, in the end, I want you to tell me which 3 types of this disease is a little bit scarier than not, okay? So for HIV, as you all know that HIV is the virus that causes, or a lot of public know, AIDS syndrome, acquired immunodeficiency syndrome. So this AIDS syndrome has been in our country since 1986. And what do you know about AIDS? A lot of time you can recall the poster that put in front of all the clinic kesehatan, AIDS membunuh, right? So it's very scary. They put a picture of skinny fella with dark spots on the skin, look very horrifying. That is AIDS, okay? But you hardly see it nowadays because of the availability of a medicine, what we call antiretroviral therapy, which we actually can control the disease and prevent the patient from becoming AIDS patient, okay? So it's no more a death sentence, and it's no more a bleak and dark future for those who had diagnosed to be HIV. In fact, I would say that the future of HIV is fairly bright, and the life expectancy for HIV patients can live up to 75 or 80 years old. So, as an introduction, we have a fair bit of population of female being infected in Malaysia. Let's look at worldwide. There are actually 16, or now currently is already 20 million women infected at the end of 2015 by WHO data. In Malaysia, up to now, we still have about 20 to 21% of populations, among all the cases that have been reported to our Kementerian are from the female group. And more than 90% of these female actually got their infections through having sex with an infected man. Definitely, okay? There are very few women who get infection HIV through needle sharing. That means if they are drug user, they are actually, but less than 10%. And the risk of transmission from a HIV-infected mother to the baby, for the viruses to pass to the baby, at overall, we are looking at around 35% only, not 100%. So a lot of public think, when I told my patient that actually you can consider of pregnancy, their eyes will become very big and say, huh? Betul ke? Is it correct? So because they thought that it is 100%. Once you get infected, 100% your baby will be infected. This is not right. So 1 out of 3 HIV pregnant mother will pass the virus to the baby. All right? This is fairly high, I would say. So we do have chances of reducing this higher risk to almost to less than 0.1%. Okay? That means out of 100, less than 1 mother will have HIV baby. All right? So what do we do to this group of people? All right? That's why I put there, if you can see, the overall risk is 35%. And during pregnancy is about 30%. And if you allow the mother to breastfeed, then another 15% chance. Okay? These are without treatment. That means the mother keep quiet. Once she knew that she is HIV positive and get pregnant, she keep quiet and do not go for any visitations of the doctors and HIV consultants. It means no treatment on both HIV and the mother, prevention to the baby, and breastfeed the baby, then overall risk is about 35%. Okay, very clear. So, sorry, I'm going backward. So what we do here now is we call it as preconceptual counseling for all these reproductive age group of female. Means that if they are young, they can actually get pregnant. We automatically engage those ladies into counseling for preconception, regardless whether they are married or not. Because number one fact that they got HIV means they are actively having sex, right? So we have to talk about this issue, whether they are married or not married, okay? So we all general goal is we would encourage all planning or all female who actually wish to get pregnant, check themselves of HIV status first, and also the partner, okay? And at the same time, we also recognize or, try to identify all the risk factors which can lead to poor mother outcome in pregnancy, like diabetes, high blood pressure, kidney disease, and also at the same time try to identify the higher risk factors for the poor baby outcome. And then we provide very, very personalized education on for female on the menstrual cycle, and also very details of telling them that what are the risks involved and in what type of sexual practices that can actually increase the HIV transmission to the husband, if the husband is negative, how to avoid the transmission to the negative husband, okay? And then we will treat whatever sexually transmitted disease that they have for both husband and wife, or partners and the lady. And then our aim is to start HIV drugs so that our virus in the blood can be controlled to undetectable level. Tak dapat dikesan di dalam darah. It didn't mean that they are cured. It's just that the virus had been very quietly controlled and will not, have the virus in the secretions of the reproductive tract. Hence, will reduce the transmission to the partner. And we stabilize the psychosocial problems also at the same time. Okay? And this is how I would like to say. We will do it through counseling and screening. And a lot of time, our patients are being married, especially from the Muslim. They will take premarital screening HIV status as the status for the whole life. Means that in 2014, she got married and she was found negative, and the husband is negative, and she thinks that she's immune already. And she will never test herself every year. And then once she get pregnant in 2016, this is a real scenario, and then she found out that she was HIV positive during the pregnancy. Because we do screen all our pregnant lady for HIV status, because there is some wonderful way we can actually salvage the pregnancy, and we can give birth to the lady can give birth to a HIV negative baby, all right? So she got surprised. She asked us, why am I, premarital that time my HIV status is negative? Why am I positive now? Okay, so you will be surprised that a lot of public think that once you are negative, you are negative for the rest of your life, which is not true, all right? As long as you have sex, there will be risk of HIV transmission, because you would not know your partners have sex with how many people, all right? So the real thing is, a lot of public need to know that just make HIV testing like fasting blood sugar testing. You would do fasting blood sugar, fasting cholesterol for the rest of your life every year anyway. So take it as long as you have sex, unless you have no sex at all right? Then you won't have a risk of getting HIV, okay? And I keep on getting backward, And then we will treat the general medical issues like psychiatric. We will refer to psychiatric to stabilize them. If they have alcohol, we ask them to stop the alcohol taking. Narcotic issues, we will ask them to do a lot of psychotherapy to handle that. And we identify whether the patients have mental health issues or violence issues at the home, so that will prevent them to be a suitable candidate for further pregnancy, okay, or future pregnancy. Then if everything goes well, everything seems to be perfectly well, ready for the female to become a mother, then we will tell the patients how to avoid transmission if the husband is negative. Okay? So here is the issue. You have a discordant couple, means one is positive, one is negative, or concordant couple, both are positive HIV. So you have only one partner. If the lady is HIV positive, well, we have to consider to start the HIV therapy in the female first, all right, and then teaching them how to calculate their circle, and then they can use time coitus. Time coitus means during ovulation only we allow, no condom usages, having sex with the husband or partner in order to get the pregnancy. With that, the HIV negative partner, of course, will have certain limited risk, a very small risk of getting HIV from this activity. In order to reduce that further, we actually had another program called PrEP. That means pre-exposure prophylaxis for the negative. We'll give some medicine for the men in order to reduce this risk. And then if the couple do not want to have natural cause of sexual intercourse to get pregnant, then they can opt for intrauterine insemination or syringe method, okay? That means take the semen and inject into the womb. And then if the HIV lady is negative but the man is positive, then we will treat the man, and then again we allow time coitus, and then for the negative lady, we will give some medicine to prevent the transmission for the HIV virus also as well. And if it's a concordant couple, means both are HIV positive, we allow them to do unprotected sexual during the ovulation time, okay? So if the lady only found out she's HIV positive during the pregnant time, all right? So we will actually start management for the mother as soon as possible, because we have a very good program called Prevention Mother-to-Child Transmission Program in our Kementerian to reduce the risk from 35% down to less than 0.1%. In fact, we are aiming 0%, okay? Thailand has got 0% already, and Malaysia, we are aiming to go for that in 2020, okay? What is our rate now? Our rate now is less than 1%, okay? So there are ways for us, a doctor, to help to reduce the mother-to-child transmission. So if they are already taking HIV therapy, we continue the HIV therapy and make sure that the mother is having a combination clinic. We always will work together with the ONG part and do screening, make sure the baby is healthy and not deformed. And a lot of people ask me whether our HIV drug will cause deformity in the baby. We have a lot of data to say that our drugs are now safe and can be taken during pregnancy and will not cause deformities, beyond extra incidents from normal occurrence, okay? And then you see that among women taking a good suppressive anti-HIV therapy, the percentage will be less than 1%, okay? So also, HIV pregnant mother will be surprised that they are actually allowed to do vaginal delivery now. Last time, no. All of them will have to go for cesarean section because vaginal delivery imposes a risk of transmission to the baby. So a lot of women actually scared of operation. As long as your virus is controlled below 400 copies, this is a very low level of virus in the blood, we actually allow the mother to have vaginal delivery, okay? And then the baby has to take 6 weeks of syrup zidovudine, which is a HIV drug. And with that, we will do about 6 tests in 2 years for the baby to check the HIV status for the baby. Most of them are negative with the proper management like that, okay? And we do not allow breastfeeding. So a lot of mothers will be very concerned, saying that, how am I going to tell in-laws that I won't allow breastfeeding? So what we always tell the mother, the new mother, say that to explain to your in-laws or to your friends that your breast milk is not healthy. Contain bacteria or things like that. We don't allow, we don't encourage people to say out their status, okay, because stigma is there. And then, with that, we hope that we have a healthy, non-infected HIV baby. And for your information, Penang State has achieved 0% for the past 3 years already, okay? So, thank you very much. It's very encouraging. And for hepatitis B, all right, we have a fair bit of population of hepatitis B around us, actually. And all these are actually got their infections through mother-to-child transmission. Because by sexual route of transmission is actually very rare now. And from 1989 onwards, all the newborn babies are given vaccine-free, hepatitis B vaccine, free from the government, and inside our national immunization program for the pediatric. So if you are born before 1989, you need to check your status. If you are born 1989, after 89, most of the younger nurses are actually hepatitis B negative already. So, but we are talking about a small populations of female could be hepatitis B positive, who got their infections through their mother during the pregnancy. So more than 50% are acquired during the perinatal area. This is old group of people. And you can see that more than 90% of infected infants will become a very serious chronic hepatitis B carrier, which can lead to cancer and liver failure. Okay? So it is not very safe because hepatitis B affect a lot of pregnancy. They cause lower gestational diabetes. They cause incidence of diabetes during pregnancy increase. The baby becomes smaller and actually born with difficulty in breathing also as well. But it has no adverse effect on the hepatitis B cause. And for the liver, we do have certain reports saying that a hepatitis B mother, when pregnant that time, the liver go into failure. Cases have been reported. Okay, and the transmission risk is much, much higher compared to HIV. All right, for hepatitis B mother, if they are chronic carrier and their hepatitis B virus is very high in the blood, they can transmit up to 70% to 90%. That means almost 100% to the baby. So hepatitis B imposes a major risk of transmission to the newborn. Okay? So look bleak, right? Look very scary, yeah? But don't worry. There is treatment available for this group of people. Okay? You can see that down in the bottom line. Laser. Down in the bottom line, if the mother is very seriously infected with high level of hepatitis in the blood, the transmission risk is almost 70 to 90%. But after delivery, we quickly give antibody to the baby and also a vaccine to the baby. The risk dropped down to 5 to 10% only. So we have a very good method to do that. So in order to do that, we encourage mother to screen for hepatitis B status during pregnancy. Now, this is not in the Kementerian program, but it is in the private program. So it is very good that if the mother booked their pregnancy in the private, they would have screened this, and you would have picked it up. But in Kementerian, we will almost always miss it, okay? So it is actually not very good, something that I have to admit, okay? But if the mother has no hepatitis B virus, means that they are already cured from it, but just carry the carrier, you can see that the risk is less than 5%, okay? So how to minimize screening hepatitis B during pregnancy or before pregnancy, and then give, after delivery, the baby a dose of antibody and a vaccine, okay? That encompasses everything already, okay? So mode of delivery, they can do vaginal delivery, and then they can do breastfeeding, because breastfeeding has not shown, if you stop the breastfeeding, it will not improve the transmission risk or reduce the transmission risk. So the mother can allow to do breastfeeding. Okay? Now, hepatitis C. Okay? I will tell you that this is the worst. Okay? A lot of people do not fear for hepatitis C. In fact, they look at HIV, they jump, and they scream, and they wear triple glove. For hepatitis C, a lot of nurses say, tak apa, can go and take blood without glove. Okay? This is very dangerous, because this is the highest transmission risk among the needle stick injury, and there's no treatment to prevent it, okay? There's no vaccine, there's no treatment, okay? So this is actually more worse, okay? So you can see that mode of transmission of hepatitis C, majority is transfusion related. Before 1986, our blood was not screened for hepatitis C. So all our old ladies would have delivery, bleeding, postpartum hemorrhage, accident, get the blood. Highly chances they might be getting hepatitis C from there, okay? And so the history of previous blood transfusion will spark the doctor to do hepatitis C screening, okay? And the course of the disease is very long, 10 to 20 years, no symptom. Nobody will know unless you do the test, okay? And then the non-parenteral, that means non-needle stick, non-blood transfusion, vertical carries a small, prominent risk compared to sexual. So mother-to-child transmission is actually more prominent. So at conception, they can transmit, or during delivery and during lactation, okay? So these are the almost same as HIV virus. But if the mother has very high level of virus in the blood, the transmission risk is almost like HIV, 36%. But the problem is in HIV we have medicine and we have ways to reduce the transmission. For hepatitis C, nothing can be done, all right? So if hepatitis C virus is there, the vertical transmission risk is as high as 16%, okay? So as long as the mother is hepatitis C, we will test the blood for virus. If the virus is detectable, we can find the virus, then we would not encourage the mother to have baby because the risk of transmission is almost 1 in 3, okay? So in other words, this is the group that I would say that it is very, very difficult unless the mother and the father would want to proceed and get the, get hold of mental stability if the baby is found to be hepatitis C positive in the future, okay? And then in the absence of good prevention mother-to-child transmission program, we said that if we can avoid all invasive procedures so that to reduce the risk of getting to the baby, so we will not do villus biopsy, that means anything that put needle into the womb. We will not do fetal blood sampling or scalp electrode. That means nothing can, we want to reduce the transmission so that the baby would not be affected or infected, okay? And I will skip this, and I would like to show you that the hepatitis C can actually cause some prematurity. That means the mother can actually give birth to the baby earlier than the time of expected delivery, okay? And however, in the cause of hepatitis C, is not associated with increased abortion rate or low birth weights, okay? So what can we do now? We will advise the future couple of planning to become a mother to screen all three, actually, hepatitis B, C, and HIV. Yeah? And if the positive hepatitis C mother, we will offer education and give a vaccine for hepatitis A and B so that we won't want the liver to go into further insult or further injury by hepatitis A and B, but not to treat the hepatitis C. Just we do not want to increase the risk of liver failure by other viruses like A and B, okay? And then we will do assessment for hepatitis C by doing hepatitis C viral load. And then if the mother insisted, even though with presence of hepatitis C in the blood, still want to carry on with the plan to become pregnant, then we will have to give them probably a course of hepatitis C treatment, which is very costly. It costs the old style, which has 50% success rate only, will cost about 50K. And the new one, which 3 months therapy and almost 100% cure rate for hepatitis C, will cost about 150K. All right? So this is government price. In private, I think it will be higher. All right? So I don't think we are in a country that has so much money. All our couples, unless you are millionaire or billionaire, for the normal earning couple, I don't think this is possible and feasible. Okay, and government do not have free treatment. Okay, and then we do not encourage emergency cesarean section. We plan for elective. Elective cesarean section is not recommended because of risk of transmission to the healthcare worker also very high. So sometimes we do not do this, and it will not reduce the incidence also as well. I mean to the baby. So breastfeeding is allowed. Okay. So you can see that screening is needed for the baby who is born by hepatitis C mother. Okay. This is very detailed, but pediatric will take over and see that whether the transmission had occurred to the baby. And in fact, the treatment that we have in government now, currently, the success rate is almost like 50% only, and a lot of side effect. It's called PEG intron and ribavirin. It's injection and oral, and the side effect is very tremendous. Not only mentally, they go into depression, some go into psychosis due to the injection, and they go into anemia, and platelet will drop. All the counts are dropping with ribavirin, another drug. This is the one that we are available, and with that also we only can treat 10 to 20 people in our setting per year. And we have more than that, all right? So we have to choose our patient and things like that. So this is my last slide. For blood-borne viruses, I would encourage all the planning to get pregnant or pregnant lady to screen for HIV, Hep B, and Hep C. For HIV, good outcome with low transmission rate after intervention. For hepatitis B, good outcome with low transmission risk with after delivery intervention. For hepatitis C, not so good outcome. Okay, especially for those mothers who have detectable hepatitis C virus in the blood. Okay, so we encourage screening before planning for pregnancy. And please remember that for HIV test, premarital HIV test, negative doesn't mean that you will be negative forever. Okay, so but for HIV and hepatitis B and hepatitis C, please go and consult the doctor, because I don't think that every one of this, if you are ever infected with these 3 viruses, termination of pregnancy is never a choice. In fact, you may actually carry on with the pregnancy, and we will help you to get a good outcome for the baby. Okay, thank you very much.